So for colon cancer patients specifically, when we're looking to make the decision after surgery as to who will benefit from adjuvant chemotherapy or systemic therapy, traditionally and historically, we've looked at items such as the T stage, node positivity, lymphovascular invasion, and then later on came the MSI high, which had a negative predictive value for adjuvant chemotherapy. But all of the other items, effectively what we were looking at is a hint or foreshadowing as to whether those patients will have some minimal residual disease or cancer cells on the microscopic level. The importance of ctDNA is now we can actually measure and quantify that MRD, and we don't have to play the guessing game anymore. And studies have shown that the positive predictive value, as well as the negative predictive value of ctDNA is much, much better, and it kind of dwarfs the other markers which we historically used. So moving forward, this, I believe, will become the new standard of care when we're trying to make up our mind and help guide the patient as to whether they will benefit from adjuvant chemotherapy or they can go on surveillance. On the flip side of it, moving forward for patients on surveillance, traditionally we've only used CEA and imaging studies to try to detect recurrence. And the idea is we want to detect it as early as possible to maybe get them back to surgery and help them achieve a cure if possible. Again, with ctDNA, we can detect MRD or recurrent disease much earlier. The studies have shown that there's a lead time of about 8 months between ctDNA turning positive and then us finding some changes on CT scans. Therefore, I think it'll be very important moving forward to utilize ctDNA in surveillance. The added benefit of that as well is we don't have to subject the patients to radiation. It's only a blood test, and then if that's positive, then they will need to undergo imaging. But it helps minimize cost, it helps minimize radiation exposure and time as well. For patients on surveillance for their malignancies, traditionally we see them every 3 months, maybe for the first 2 years, then we stretch it out to every 6 months. We're doing scans, we're doing in-house phlebotomies to check for blood counts, to check for CEA, for example, in colon cancer, to be able to do the surveillance remotely as we shift more to telemedicine, and to be able to have a phlebotomist go to the patient's home directly and test them for ctDNA and try to avoid coming to the hospital, going to radiology centers. That has been a huge benefit in this COVID pandemic era. And I believe this will change the way we practice medicine, especially cancer surveillance, moving forward. Signatera has established this expanded access program, which is extremely beneficial at this time of COVID-19, where we're all trying to do social distancing, trying to protect our patients, protect our staff, trying to minimize exposure. This also is very important for our cancer patients because, as we all know, chemotherapy is immunosuppressive, and that puts them at high risk of becoming neutropenic and being exposed to COVID-19 and developing serious complications, even death. That is where ctDNA can be extremely beneficial, where we can more accurately identify who are the patients who will not benefit from adjuvant chemotherapy, who we can avoid chemotherapy in those patients and avoid exposing them to the toxicity of chemotherapy and decreasing the risk of contracting COVID-19. The importance of the expanded access program is it eliminates that financial part for the patient. As we know, a lot of testing today can be very expensive, and patients, a lot of times when they have to choose between potentially life-saving procedure or test and not having the resources for it, a lot of times they choose to forego that test, unfortunately. So for them to have access to that program for all GI malignancies, not just for colon cancer, has been a huge help so far. I had a 49-year-old female who 2 years ago, she was diagnosed with stage 1, T2, and 0 sigmoid colon adenocarcinoma. She underwent resection, 26 lymph nodes were collected, and those were negative. And she went on surveillance afterwards. About 3 months ago, she developed new rectal bleeding. On repeat colonoscopy, she was found to have recurrence at the site of anastomosis. She underwent re-resection. It was a T3 and 0. 16 lymph nodes were collected. The margins were very close. No further resection can be done because of adhesions from her previous surgery. And she was MSS. So now we have local recurrence in a young lady at stage 2, T3 and 0 colon adenocarcinoma. And the question becomes, will she benefit from adjuvant chemotherapy? This is the second time she develops cancer. You can make the argument that it is recurrence at the site of anastomosis, which could be insufficient resection at the primary surgery 2 years ago. Or could it be that she did have MRD, which would have been eliminated with adjuvant chemotherapy? The patient, if we go strictly by the guidelines present before ctDNA MRD testing, she would probably get some adjuvant chemotherapy, 3 versus 6 months to be determined. But now that we have this data and we know that we can test her to see if she has any MRD using ctDNA, using her specific gene sequence from the original tumor, this might save the patient 3 or 6 months of chemotherapy. It will prevent exposure to cytotoxic or myelosuppressive chemotherapy that can increase her risk of contracting infections, especially COVID-19. So we went forward and proceeded with ctDNA testing. We're still waiting on the results of that, but it will be the determining factor as to whether she needs some adjuvant therapy. The patient was very excited with this prospect. The fact that she might be able to avoid chemotherapy altogether is something patients are always looking for, and we are looking for it as well.